Hello, my name's Kevin Fernando. I'm a GP partner, family doctor near Edinburgh in Scotland. I've had a long-standing interest in all things diabetes, cardiovascular, renal, and metabolic, and actively involved in medical education for primary and secondary care. I also work for Medscape 1 day a week, and I'm honorary clinical reader at the University of Dundee. I also have a strong social media presence on Twitter, YouTube, and TikTok as well, where I post both healthcare professional facing content and also a person facing content as well. These are my disclosures. So, in this session, I'm going to talk about what we need to know in primary care about obstructive sleep apnea hypopnea syndrome, OSAHS, which is under-recognized and under-managed in primary care. OSAHS is a sleeping giant. If untreated, if unrecognized, OSAHS is associated with neurocognitive impairment, with an increased risk of cardiometabolic disorders such as type 2 diabetes, cardiovascular disease, hypertension, and importantly, an increased risk of all-cause death. So this is a condition that affects both quality of life, but also quantity of life too. Furthermore, people living with OSAHS are at a 10 times increased risk of being involved in a road traffic accident. So, again, if unrecognized, this is a condition that can affect others in the community too. So, OSAHS is a part of a spectrum of sleep-related breathing disorders, ranging from simple intermittent snoring to severe cases of obesity hyperventilation syndrome, what we previously called Pickwickian syndrome, which is characterized by hypoxia, low blood oxygen levels, hypercapnia, elevated carbon dioxide levels, and sleep disordered breathing. And we see progression across the spectrum as weight increases. So, how common is OSAHS? Well, OSAHS affects around 6 to 13% of adults in the United Kingdom. So, it's at least as common as people living with type 2 diabetes. So, again, something we do need to take very seriously indeed. And certainly for all of us working in primary care, common presentation is being tired all the time, fatigue, malaise. At least 1 in 4 of these presentations of being tired all the time is an undiagnosed sleep-related disorder, such as OSAHS, such as related to sedative medications, for example, amitriptyline or benzodiazepines, or an insomnia disorder. So what happens in OSAHS? Well, for normal breathing requires a patent airway from the nose all the way down to the lungs. So anything that obstructs this airway can potentially cause a sleep disordered condition. So a deviated nasal septum, chronic rhinosinusitis, increased adiposity around the neck can cause a nasopharyngeal collapse. Of course, a range of lung conditions such as COPD, chronic obstructive pulmonary disease as well. So what happens when we have this airway obstruction is it leads, of course, to sleep fragmentation. The airway partially collapses, hypopnea, or totally collapses, apnea, resulting in shallow breathing or complete cessation of breathing. But that's, of course, when our central nervous system kicks in and stimulates catecholamine and other hormone responses to awaken that individual to start breathing again. So that is, in essence, the underlying pathology that happens in OSAHS. The big key take-home message for us, this fragmented sleep we see in OSAHS and other sleep-related disorders leads to autonomic nervous system dysfunction. And it's this autonomic nervous system dysfunction that leads to increase, again, catecholamines, other inflammatory cytokines, and this is what leads to this increased risk of adverse cardiometabolic disease, okay? Of course, we need to be aware of the hypoxemia and the symptoms associated with that, an impact on quality of life, but we're increasingly aware now of the adverse cardiometabolic impact. So, who is likely to be affected by OSAHS? We see a higher prevalence of OSAHS in patients living with type 2 diabetes. It's estimated 1 in 4 people living with type 2 diabetes will have underlying OSAHS. So, certainly, this has changed my practice. I'm actively asking individuals living with type 2 diabetes, how are you sleeping? Are you waking up choking, for example, through the night, or waking up with a headache or feeling like you've had an unrefreshed night's sleep? So I'm actively looking for sleep apnea in my patients living with type 2 diabetes. But that relationship is bidirectional. Up to a third of people living with OSA, obstructive sleep apnea, have type 2 diabetes. And that's also changed my practice because, in my patients who've been diagnosed with sleep apnea, perhaps are on CPAP, I'm actively checking HbA1c, glycosylated hemoglobin, to make sure I'm not missing a coexisting diagnosis of type 2 diabetes. So very much a bidirectional relationship. High prevalence of OSAHS, of course, in people living with obesity or overweight, and really anyone with a range of cardiovascular disorders, cardiovascular arrhythmias such as atrial fibrillation, a background of cerebrovascular disease, TIA, stroke, and heart failure. All subtypes of heart failure, HFrEF, heart failure with reduced ejection fraction, and particularly HFpEF, heart failure with preserved ejection fraction. Those with known respiratory disease, chronic obstructive pulmonary disease, COPD, I mentioned, also moderate to severe asthma. PCOS, polycystic ovarian syndrome, that also sits on this insulin resistant spectrum, as does type 2 diabetes, as does OSAHS, and those living with hypothyroidism. A notable comorbidity, or a notable group of individuals we see a higher prevalence of OSHS is people with treatment-resistant hypertension. Now, this is a fascinating relationship, and again, has really changed my practice. So, we all know in primary care, treatment-resistant hypertension is common. Most of our patients require 2 or 3 drugs, don't they, rather than monotherapy to manage their hypertension. Prevalence varies, but it's thought to affect resistant hypertension is thought to affect about 10% of people with treated for hypertension. And my usual treatment for hypertension is an ACE or an ARB, then maybe add in a diuretic, calcium channel blocker. And if they're taking their meds regularly, of course, we need to check for adherence. But if they've still got the blood pressure above target, I would add in low dose spironolactone, 25 milligrams once a day. And that has really been driven by the Pathway 2 trial that was published a number of years ago now, but really tells me that the optimum fourth line choice of antihypertensive in treatment-resistant hypertension is an MRA, a mineralocorticoid receptor corticoid antagonist. But what is the connection with sleep apnea? Well, what data tells me is the prevalence of OSAHS is up to about 30 to 50% in hypertensive individuals and up to 85% in those with resistant hypertension and over 90% in those with refractory hypertension. So actually identifying and importantly managing OSAHS in people with treatment-resistant hypertension may play a very important role. So how has this changed my practice? Well, next time I reach for a prescription for spironolactone, I'm asking myself, could this individual have underlying sleep apnea that's driving their treatment-resistant hypertension? Of course, check for all the usual lifestyle stuff. Make sure they're taking their antihypertensive medications. But if they are, do screen for OSAHS. And I'll tell you how to do that in just a second. So when do we suspect OSAHS? Sleepiness, of course, is a feature of OSAHS, but remember, it can sometimes be associated with insomnia as well and sleep disruption. So we should suspect OSAHS if there's 2 or more of the following features. Snoring, if a partner, loved one has witnessed apneic episodes, so complete cessation of breathing for a few seconds, and then individuals often coughing themselves awake again. If people tell you they wake up and they feel like they've had an unrefreshed night's sleep, if they wake up with a morning headache, if they have unexplained excessive sleepiness, tiredness, or fatigue, nocturia, choking during sleep. Again, patients might, of course, notice that themselves, or again, a loved one or a partner might notice that as well. Or do they tell you they're feeling just a wee bit knocked off, cognitively not quite there? Are they describing cognitive dysfunction or short-term memory impairment? These would all raise our suspicion of OSAHS. So we commonly use the Epworth Sleepiness Scale, don't we, in primary care, which is an excellent scale. But remember, this is purely to assess sleepiness rather than to diagnose OSAHS. So really the key message for us in primary care is we shouldn't use the Epworth Sleepiness Scale alone to determine if a referral is needed to our respiratory sleep colleagues. We need to do the ESS, Epworth Sleepiness Score, but we also need to do the Stop Bang questionnaire, okay? So the Stop Bang questionnaire is a simple to do questionnaire in primary care. It's an acronym for a number of features: snoring, tired all the time, are people overweight, blood pressure, body mass index, age, neck collar size, and also gender, male gender, increased risk of OSAHS. So you score individuals on this Stop Bang, and if they answer yes to 5 of these 8 questions, that suggests a high risk of OSAHS, and we should of course consider a referral to respiratory sleep colleagues. Okay. So lastly, just a few tips on management of OSAHS. Of course, the management of OSAHS is very much driven by our respiratory sleep clinic colleagues and the consideration of CPAP, continuous positive airways pressure. What CPAP does, it maintains a patent airway and stops those episodes of shallow breathing, hypopnea, or complete cessation of breathing, apnea. And what CPAP does is overall improve sleepiness, of course, alertness, and importantly, overall quality of life. But importantly, CPAP also mitigates that risk of future adverse cardiometabolic complications. So that's what often our respiratory colleagues do. What can we do in primary care? Well, of course, in primary care, we can reinforce those all-important lifestyle advice. We can counsel about weight for our patients living with overweight, obesity, maybe refer to a weight management service or a local exercise referral pathway. We can talk about smoking and support smoking cessation. Smoking, in those who are smoking, of course, there's ongoing inflammation in the lungs, and that also drives airways resistance and can worsen sleep apnea. We can also counsel about alcohol intake and ensure individuals with sleep apnea are drinking alcohol within recommended limits. Because what alcohol does, it relaxes the muscles in the neck. It causes nasopharyngeal relaxation, which can also cause airflow impedance. Practical things we can do, we can ask patients to sleep in a lateral position rather than a supine position. Of course, challenging to do, but using some extra pillows, or actually some of my patients sleep with a wee rucksack on their back to force them into a lateral position. A big thing we can do is review those medications and stop sedative medications such as amitriptyline, as I mentioned, muscle relaxants, baclofen, for example, and importantly, we should especially stop benzodiazepines as well. And then finally, driving advice. Driving advice is very important when making a diagnosis or managing someone with sleep apnea. So driving licensing rules, of course, vary across the globe, US, Europe, elsewhere in the world. But the common themes are OSAH self is not the problem. Tiredness and sleepiness are. Ultimately, it's our patients that are responsible for deciding whether they are fit enough to drive or whether they're too tired or sleepy to drive. So it doesn't matter if you have suspected sleep apnea or established sleep apnea, or you've been awake through the night with a new baby, or you were binge watching the latest Netflix series. If you're too tired to drive, you shouldn't drive, okay? So if the sleep clinic does diagnose sleep apnea, but they say that the sleepiness during waking hours is not excessive, then your individual living with sleep apnea can drive. But however, if the sleep clinic diagnoses moderate to severe sleep apnea with excessive sleepiness, that individual mustn't drive until they've been given the green light from the sleep clinic. And this slide here shows you the Sleep Apnea Trust. It's a UK-based patient support charity, but very relevant for patients with sleep apnea from around the world. The charity works with various organizations to help improve the lives of people with sleep apnea, their partners, and their family. They have some great resources for us as healthcare professionals, but also for people living with sleep apnea. So I hope that gave you an insight into what we need to know in primary care about OSAHS, obstructive sleep apnea hypopnea syndrome, a sleeping giant, under-recognized and under-managed in primary care with significant impact on both quality and indeed quality of life. So hopefully with increased awareness, if we can establish that diagnosis early on, we can make a significant difference to that individual's longevity. Thanks for listening, everyone. I hope you found that helpful.